for Jason. So, oh my gosh, I have things going on. Anyway, as we always start our grand rounds, we'll start with a land acknowledgement. So Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. And CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. I'm happy today to introduce our visiting speaker, Dr. John Halamka, sorry for that, who is from the Mayo Clinic. Dr. Halamka is an emergency medicine physician, medical informatics expert, and president of the Mayo Clinic platform, which is focused on transforming healthcare by leveraging artificial intelligence, connected healthcare devices, and a network of partners. Dr. Halamka has been developing and implementing healthcare information strategy and policy for more than 25 years. Previously, he was the executive director of the Health Technology Exploration Center for Beth Israel Lahey Health, the chief information officer at Beth Israel Deaconess Medical Center, and international healthcare innovation professor at Harvard Medical School. He is a member of the National Academy of Medicine, and we're so fortunate to have him here today for our pediatric grand rounds. Welcome, Dr. Halamka.
Well, I'm a very informal person, so John, and welcome and good morning from Mayo Clinic. I'm in Rochester, Minnesota at the moment, where I did do a centigrade conversion. It is minus 18 centigrade, where it's minus 27 by wind chill. So a lovely morning to discuss artificial intelligence, informatics, and platforms. So I think many organizations throughout the world are asking this question, and I will use a few slides to illustrate some points, but they're asking this question. Do institutions, given their incredible clinical expertise and their historical data, have an opportunity to create an extraordinary new approach to care? And can that new approach to care, of course, putting the patient first, leverage artificial intelligence and emerging technologies, and do so in a way that is fair, appropriate, valid, effective, and safe? And so today what I'd like to do is take you on a journey. Mayo Clinic in 2019 decided that as we look to 2030, the nature of the care we deliver, how we deliver it, who we deliver it to, is going to be fundamentally different. And so we need to do preparation for scale of new kinds of digital health, new kinds of artificial intelligence, and new kinds of care models. So let me move over to some slides and just checking, can you see the slides okay?
Yes.
You can.
Perfect. Thank you. So Gianrico Farrugia, the CEO of Mayo Clinic, always reminds us to put the patients first. And so rather than say we're going to implement new technology, or we're going to implement AI, or we're going to do something to revise our care model, let's ask the question, how do we keep the world as healthy as it can be? And how do we achieve that? By capturing specialty knowledge. And yes, using technologies as part of that, but it's not technology for technology's sake. And then a series of objectives. Let us make our own practice better, but let's bring partners and collaborators from around the world together to capture knowledge and create new solutions. And let us ultimately transform healthcare. And what we do, the risks we mitigate, the successes we have, the failures that we have, can be spread to the point where multiple societies across the globe are doing the same kinds of things. The goal he gave me, he said, John, by 2030, I want 4 billion people touched by the work that we're doing. And whether that's the curation of their data and their local country or region, or the use of AI, but somehow they're going to be touched by this work. So 4 billion. And I know that sounds a bit like hyperbole, but you'll see how we achieve that goal, including many colleagues in Canada. Mayo Clinic, like many organizations, sets up a strategic plan. Mayo works in 10-year planning cycles. And the 2030 plan, our bold forward plan, is about cure, connect, and transform. Now, cure, of course, that means discovering new cures. That is reducing the burden of disease, focusing on wellness and prevention, early diagnosis. And part of that, of course, will be building new digital solutions which connect our physicians and our nurses and our patients in novel ways. And so there will be some novel tools, which I'll describe. But transformation is to say, we are going to be able to see more patients in more localities with more serious and complex disease while using emerging AI technologies to make it easier for all, reducing burden and ensuring that we have appropriate resources to spread an increasingly wider world of those needing healthcare. In the Cure, Connect, Transform plan, what I am running, this Mayo Clinic platform, is the transformation piece. So I'll go through some detail about how we're doing this at Mayo globally and some of the not only technology, but policy and cultural change around it. So here's one of our great challenges. And I have been working for 40 years at the intersection of healthcare technology and policy. The use or secondary use of the data of our patients of the past is one of our most extraordinary tools to help our patients of the future. But how do we use that data in a privacy protected and ethical manner so that everyone in the organization, everybody in the regulatory framework, all of our patients think it's reasonable, it's okay? So here's what Mayo did. Starting in 2020, what we recognized, we had 10 million patients' lifetime experiences. Question is, could you de-identify 10 million patients' lifetime experiences in such a way that that knowledge could be captured by organizations outside of Mayo, researchers inside Mayo, everyone working together? So we started with the structured data, problem lists, medications and allergies and labs. And that's not so hard to de-identify. You remove the 18 HIPAA identifiers in the United States, or looking at your privacy law, what are the things that are not to be shared? Remove them. The text or unstructured data, the notes, the reports, the H&Ps, that's a much harder set of data to de-identify. Because although you might remove the name, the phone number, the medical record number, if that note said this former president of the United States, well, it doesn't have a name, but the number of living former presidents of the United States is few, and therefore the data would be easily re-identifiable. So we had to develop a process that uses natural language processing and machine learning to read billions of notes, everything ever written by any clinician in the history of Mayo Clinic, and look for things like job role, geography, familial relationships. And then we did something called hiding in plain sight, where hiding in plain sight means instead of former president of the United States, we'll just say this politician. Okay, well, that's a lot of people, and that's going to not be so re-identifiable. So every name or geography, familial relationship, all replaced with something that is not real, but is reasonable. And in so doing, we moved 100% of all of our historical records to a cloud container under our control. And then we began to march through other modalities like imaging, telemetry, EEG, genomics, pathology. And so the end result today is we have this limited use, de-identified corpus of multimodal data for the generation of AI or analytics, visualizations, research, distributed clinical trials, all in cloud containers. But that's not sufficient. Mayo may have 10 million, but those are patients who mostly are from Minnesota, Florida, and Arizona. And so what about if we're going to ensure equity, if we're going to ensure fairness? As we start to look around the world, well, where are the other places that are really good about curating data and want to join the journey? Mercy Health, and they're in 3 states in the United States, Arkansas, Missouri, Oklahoma. They said, yes, we'd like to be part of this. And they brought 12.8 million patients. They didn't send the data to Mayo. They just agreed to de-identify it, put it in a cloud, and use the same kind of tooling so that collaborators could go to either Mayo or Mercy, have the same experience. Then Sheba in Israel added 1.4 million. UHN in Toronto added 2.4 million. Albert Einstein in Brazil added 3.3 million. So you can see up to about 30 million birth to death, de-identified, multimodal, longitudinal records. And that starts to constitute a diverse enough data set. It's got depth, many data types, breadth, it has many patients, and spread, it has heterogeneity. It has the old, the young, the male, the female, the white, the black, rural, urban, educated, not. And that starts to give you a basis for starting to develop AI models that are going to be generally useful. Now, again, this is just a start, because you'll see next month we'll be bringing on 5 other organizations. Apollo is bringing the data of India, Sing Health, Singapore. In Korea, Seoul National. There are a couple of domestic systems in the United States we'll also announce. So we'll start in 2024 to get to more like 100 million patients. And then after that, there are 21 countries on the planet where electronic records are stored with reasonable fidelity. There is reasonable infrastructure, regulatory friendliness, and urgency to be part of doing ethical AI. When you add it all up, it's about 2.9 billion patients. So it is not absurd to believe, when I started the conversation today, oh, we're going to end up touching about 4 billion people. Well, at the moment, we've got sight on about 3 billion as part of a distributed, federated network of organizations working together to curate data and develop new models. Let me tell you about how that all works. So you've heard a foundation of data. And of course, a lot of that data has to be pediatric data, since I'm talking to you folks. And we do have a number of pediatric hospitals engaged. So once you've got de-identified data that's appropriate for what you want to do, you then want to start developing solutions, where solutions, as I said, could be predictive or generative AI. I'll describe a few of those, describe the life cycle. And the more data you have, the more solution developers, internal and external, you start to attract. You never sell data. You never move the data out of your control. It's bringing these solution developers into the cloud container, where then they can create novel algorithms. Those algorithms can be tested, and the algorithms may leave, but otherwise everything is kept private and fully audited and under the control of those who generated the data. So it's a pretty reasonable model. Mayo at the moment has graduated 40 companies from its accelerator as solution developers, 50 mid-sized to larger companies as solution developers, is working quite extensively with organizations around the world, including the pharma industry, on developing solutions. Once you've got a body of solutions, then you can start to deliver them in workflow. One of the hardest things to do is to take a wonderful validated algorithm that is going to do good and move it into workflow in a way that is helpful and non-invasive to the clinician day. I think we all would agree. I mean, it might be 2 things. Working with EHR vendors, whoever they are, it's not so easy. And so figuring out that workflow integration and engaging your EHR vendor may not be the best approach. Secondly, more pop-ups, more distractions, buttons to push, or different user experiences will result in no clinician adoption. So what has Mayo done? We've developed a mechanism for the technically minded today. It's a smart on fire sidecar that sits next to the electronic health record in workflow, maintaining the context of the patient and the patient's data and showing the result of AI algorithms running for the benefit of the clinician without distraction, without burden, without requiring a different login or a different user experience. And we've done that now for 240 different algorithms, many of which have been taken through FDA approval or put through randomized clinical trials. And so we now have the capacity for any solution generated by anyone to place it in electronic health record workflow as appropriate when it's gone through approvals and governance and quality certification and that kind of thing, in a way that is going to benefit the physicians and the patients through the addition of decision support and reduction of burden. Again, I'll show you some examples in a moment. So this is a bit what the ecosystem starts to look like. Okay, you've got all these solution developers, you have all these organizations working to provide data, and this is done in a peer-to-peer fashion with total reciprocity. What that means is, you see, this is not a hub and spoke approach with Mayo at the center. No, this is, UHN Canada can work with Sheba. Mercy can work with UHN. Everybody is just part of a community of peers, and not only providing the technology in a common fashion, but governance and policy making. Just last week, I had the leadership of UHN and Sheba and Mercy and Albert Einstein and Mayo in Jacksonville, Florida, as we started to describe distributed clinical trials and how we would all work together and where would data be institutionally identified and not, and those kinds of things. So a fairly good model. As these solutions need to be deployed, and adoption is certainly one of our KPIs, you ask, well, do you put them into academic medical centers, or might you want to place them in community settings, critical access hospitals, those that are not likely to develop AI on their own? John Rico Ferrugia, the CEO of Mayo, did something kind of interesting, which is we have 73 community hospitals in 37 health systems. And he asked that all those hospitals report to me. And he did that for the reason that the community hospitals are likely to have the greatest benefit, and most importantly, dissemination of innovation more quickly to them will really accelerate their solutioning, their reduction of burden, their service to their patients. So initially, a lot of these solutions are getting deployed in more community settings, and these community settings are across the US for now, but there'll be also several global distributions in 2024. Just want to give you a sense, and you probably live this every day, so you know that as you look at the data that we gather about our patients, some of it is the standard electronic health record, but some of it lives outside the electronic health record. Such things as digital pathology and genomics. Some of it may be is siloed in departments, maybe registries, maybe unique modalities, retinal scans, or analyses of tissue that haven't actually been part of an EHR standard data set. So what we've had to do is identify every source of data at Mayo, and then be able to bring it into that de-identified data set quarter by quarter by quarter. And that's what we've done. This just shows you the end of 2023 as we completed a whole variety of modalities. And interestingly, we have digitized 12 million pathology slides. So the data set includes not only all the phenotypic data and the genotypic data, but even the tissue data. So when you start to develop AI models, the richness of the data types that you have to draw on is quite high. Here's just some examples, and I wanted to drill down on some of these and also reflect a little bit today on generative AI and where all that's going. So one of the things that we've recognized is that every physician is trained as an apprentice, which means you're as good as the patients of the past you have seen. I am an emergency physician. I've seen 10,000 patients. So I'm as good as those 10,000 patients have taught me. But as you've seen, we now have access to 100 million patient journeys. Shouldn't you be able to develop predictive AI models on the experiences of 100 million patients and help clinicians by augmenting, not replacing, augmenting some of their decision making? So let's look, for example, at gastroenterology. The very best endoscopists miss about 15% of the small polyps because the prep may not be great or they're just hard to see. And in the nature of endoscopy, there's a lot of shadow and contrast. Mayo developed an algorithm by taking every endoscopy test ever done and digitizing it and making algorithms identify polyps with human reinforcement of review of images. And the end result is the algorithm working with a human will only miss 3% of small polyps. So in effect, again, it's not ceding the decision making to an algorithm, but it's working in an augmented fashion. A physician could be 5 times better with the algorithm providing safety checks and overreads. In the field of cardiology, we have 14 FDA-approved algorithms that do such things as take your lead 1 ECG from the wearable you might have on your body and be able to, believe it or not, measure your ejection fraction and do that with an AUC of 0.92. And we've done a 6,000 patient clinical trial, tested it against ground truth by doing echoes. So in effect, today, from a wearable, we can say, oh, well, what's the nature of your heart pump strength? Is the medication you're taking helping? Are you having worsening heart failure? All algorithmically identified in real time. And some of these other algorithms do things like look at progression of pulmonary hypertension or valvular disease or cardiomyopathies. So care at a distance, continuous monitoring at a distance, diagnosis at a distance. And Mayo has spun out a company just to make sure the world gets a hold of these algorithms, sometimes embedded in devices. Some of the things we've done in radiology include early detection of brain bleeds, pneumoperitoneum, or pulmonary embolism with real-time overview of every film as it comes out of the scanner. Early disease detection includes such things as, can I forecast who is going to develop breast cancer or who is going to develop colon cancer? And bring those detect disease at stage 0, not stage 4. One interesting example of that, my father-in-law died 13 years ago of stage 4 pancreatic cancer, diagnosed as it typically is at stage 4. With algorithms developed at Mayo today, we can look at abdominal CT and diagnose pancreatic cancer on average 2 years before a human. And that means at stage 0 when it is curable. And so you start to see this pattern of 100 million patients developing augmented decision making, helping in fields of cardiology, GI, neurology, behavioral health, radiation oncology. It starts to make this specialty knowledge that we're accumulating more accessible to others and working together as a community, a global community, all of us sharing our discoveries and innovations with each other. Sometimes those innovations have to be just changes in the way we deliver care. A lot of what COVID taught us is that the standard bricks and mortar visits or bringing patients to a hospitalization may not be always the right thing to do. I mean, do you really want your immunocompromised and your COVID patients together in the same building? Starting in July of 2020, we developed something called Advanced Care at Home, taking a number of remote patient monitoring technologies and algorithms like the ones I've shown you, and beginning to treat serious and complex illness in the home. We started with one patient, a 87-year-old woman with a serum sodium of 102, treated her back to health, healed the whole household, had to deal with all the social determinants of health and the family dynamics and everything, learned a lot. Then we went to 10 patients, then 100 patients, then 1,000 patients. And as of now, we've treated about 30,000 patients in the home. Patient satisfaction, a net promoter score of 94%, very high. Nosocomial infections, well, 0. Who has MRSA in their living room? We hope no one. Falls and other complications, wildly reduced. Readmissions, 25% of standard, cost about half. So again, starting to look at new care models. And we're now in the midst of a clinical trial called Cancer Care Beyond Walls, where Mayo, from a command center in Florida, is doing end-to-end cancer care in North Dakota and showing that we can do it with safety, quality, and patient satisfaction. And we only will spread these ideas once they're proven to have appropriate safety and quality and outcomes and regulatory oversight as needed. So it gives you some sense of the things that working with data and solution developers can then lead to. I want to spend a moment talking about, as you are on an AI journey, well, what is it that you should put in place? Everything from data governance to validation and review to ongoing monitoring. So what we call the wheel of AI. So you wake up and you say, I have a great idea for an AI model. It's going to reduce the burden of disease. It's going to democratize specialty knowledge. Great. What data do you need to develop such a model? Do you have the data available? Is it curated? Is it high quality? Is it representative of the patient population you wish to treat? And once one has such data and does what we call a data card, looking at that heterogeneity and the subgroup analysis, making sure it's good enough, then you start to add to the data, making sure that it has human annotation as need be. You develop the model. And once you develop the model, you then take the model and run it against a different data set, get a sense of how does it perform. And you may do that locally, but then you might want to do it at other sites. And as you saw with that global network, the idea of being able to take an algorithm developed in Ottawa and then go run it in Rochester, Minnesota, or run it in the southern part of the United States, understanding it, whether it works or not, very important. Then regulatory approval. In the case of the US, we have our FDA software as medical device, or Europe, the CE mark. There are regulators that will look at AI algorithms, and some will need scrutiny and approval. And then deploy it, integrate it into workflow. Get a sense of usability and user acceptance and feedback. And then look at outcomes. Did it make a difference? Did it get used? Was there an impact? And this is not just a one and done kind of cycle. This is a continuous process improvement. And this is what we've put in place for all the 240 algorithms we've developed. But let me tell you, just nationally and globally, there are a few things about this wheel of AI attracting the attention of government. I was at Davos, and the World Economic Forum was supposed to talk about climate change and such things as global conflict. The entire focus was AI. How are we going to roll out all this new AI, predictive and generative, and do no harm? About 2 years ago, a number of us got together from government, academia, and industry and said, we better, as a community, figure out the answer to the question of what's good enough and how, for each of these steps in the wheel, do you have a regimented process? And let's standardize that process. And we created something called the Coalition for Health AI, or CHEO. You'll find it at coalitionforhealthai.org. It now is 1,500 global organizations working together, including the FDA and the White House, in creating the guidelines and the guardrails for the effective use of AI. So download, you'll see our artifacts for each of the elements of the wheel. And ongoing working groups are continuing to create implementation guidance and deal with emerging technologies like generative AI. On October 30th, President Biden signed the executive order for the trustworthy, safe, and secure use of AI. And at that White House signing ceremony, the president of Mayo Clinic was sitting next to President Biden. And that was, again, purposeful to indicate that one of our earliest needs for safe and effective AI guidelines and guardrails will be an effort with the Coalition for Health AI on putting in place very regimented approaches to this wheel. Here are just a few of the companies that are solution developers. I'm not advertising any product or service. I have no conflict of interest. It's just, you could see they come from a whole variety of countries, a whole variety of specialties. They do everything from predict seizures based on wearables to predict care journeys for a given patient, given on the patients like them in the past, to helping with prenatal care and understanding those at risk for certain complications. And we continue to expand that list every day, bringing them in to the de-identified data to create innovation. Well, when I'm talking about innovation, I do want to reflect for a moment on generative AI. I mean, you can't get by a day without seeing some headline about ChatGPT or other generative AI product. I think you all know that generative AI predicts the next word in a sentence. It isn't cognitive. It doesn't have any measures of quality or accuracy. It's just saying, I looked at 1 billion sentences. For now, the sentence I'm writing, what's the next word likely to be? I would argue that medicine is not about the next word in a sentence. It's more the next event in a patient journey. So Mayo has a series of 10 generative AI projects in flight, one of which is something we call a large medical model, not a large language model, that is taking every event in every patient's life and then training the model to say, okay, a patient with the following characteristics has just arrived, signs and symptoms and history and phenotype and genotype. What will the next steps look like? And the model then suggests lab tests to order, medications to give, therapies to try, all kinds of different suggestions based on looking at events, not words. So that's in testing now. We have a variety of what I'll call small language models. Can you train generative AI to read a chest X-ray and write the report, or interpret ECGs, or take highly complex language, simplify it for the patient, creating nursing notes and care plans, helping clinicians reduce the burden of documentation, helping them with workflow and responding to email, right? All these kinds of things. In testing now, the only thing we've actually deployed in production are things that are lower risk and more administrative in nature. And that is helping with things like billing and coding and revenue cycle, supply chain, and the creation of certain kinds of documentation. Because we know if there are hallucinations, fabrications from the generative AI, we really don't want the generative AI making decisions about our patient care journeys quite yet. We need to continue the development in our 10 projects and reduce the amount of fiction and hallucinations before these things would ever be used in a live clinical setting. So there you go. This is the number of collaborators that we have and their global locations. You'll see in 2024, adding 21 new countries and continuing to get data curation, solution development, and adoption of these solutions on a global basis. And you might want to ask, well, what does success look like? Our hope is, in the case of cardiology, being able to use algorithms to diagnose disease globally before it causes harm. Understand who is going to have a complication in surgery and avoid that part of the journey. As you heard, whether it's pancreatic, breast, whether it's a lymphoma, diagnosing cancer at an earlier stage when it's curable. Being able to be very integrative with all of our data sources, identify new therapies, be able to deliver new care models like hospital or cancer care in the home, be able to diagnose disease with less pain, less expense, and less of invasiveness, and ultimately serving a whole variety of patients we've never served before. As I mentioned, a lot of low and middle income countries in 2024 will start to see the impact of some of these algorithms as we deploy them in places like Kenya, Nigeria, and Northern India. So with that, would like to turn it back to you, and I look forward to the dialogue.
Thanks very much, John. Sorry, I was just trying to find my unmute button, and apologies for not being able to be on for the introduction. And I want to thank Dr. Johnson for doing that, but I have been listening the whole time. And thank you for a very thought-provoking and stimulating presentation. I particularly like the description of how we learn from our past experiences, and as clinicians, we're limited by the number of patients that we've seen and how that can be augmented and amplified through AI. We have a growing AI program here at CHEO looking at using AI in child health, and I know members of our AI team are on, as well as many clinicians and researchers, and so I'm sure there's going to be some great questions, but maybe I'll lead off with a two-part question. One is, it resonated with me, your discussion of reaching out to community hospitals, whether AI should exist only in academic centers. And at CHEO, we pride ourselves on being a linker with many community organizations, and have a program called Making Kids Count, where we're linked to 60 different community organizations in a bit of a hub and spoke type model. And so I wonder if you could speak to some of the unique challenges and opportunities of bringing AI and technology into the community. Are community-based organizations more likely to be adopters, or more likely to be resistant to seeing this as something foreign or being imposed upon them by the academic center? That's my first question. My second question, you touched on this a bit in your talk, but is how do we choose projects to prioritize? Is it all based on available data? Is it based on, which team is sort of jumping up and down the loudest and wants to go first? How do we make those decisions? So over to you.
Well, both brilliant questions. And so remember that I was Chief Information Officer of Harvard and its hospitals for 25 years. And so being a former CIO, what I know is that you never have enough resources. The demand will always exceed the supply. So if you go to a community hospital Chief Information Officer and say, guess what? We're going to deploy a bunch of AI in your workflow, the Chief Information Officer may say, I can't even keep email running or deal with ransomware. I don't have the resources to be able to deploy these things. So what we found is really important is that do AI rollouts with minimal burden to that local IT and technology team. And so in our case, a lot of our community hospitals happen to run Meditech or Epic. And we have been able to, as you heard, create a smart on fire wrapper that once you just put it in, it's like you can inject anything into the smart on fire wrapper, and IT does not need to be involved. I mean, obviously they might want governance and discussion, communication, but it doesn't mean they have to distract their existent agenda to take in these new AI innovations. So be very sensitive to resource and competing demands of these local organizations. And here's how you sell it, so to speak. I don't mean sell monetarily, but sell the idea. If you go to a clinician in a community hospital and say, would you like a bunch of new AI? They say like, no. Would you like to get home to dinner with your family every night of the week? Oh, that would be amazing. Well, what if I could take 20% of your administrative workload away so that you see more patients and get home earlier? I want that. So give them an impactful result. Don't talk about AI for AI's sake. Prioritizing projects. Again, having done this for decades, be very careful of a political decision, a loud voice, those who are in line first. It has to be objective. And as you said, of course, if somebody says, I want to do an AI project and it requires toenail length on 1 million patients, of course, I made that up. Well, no one's recording toenail length, at least I am unaware. And so that doesn't seem like, as you pointed out, if the data that is necessary for the project doesn't exist, then certainly that project should be deferred. But here are 5 categories you could use. Question, is it strategic? Well, imagine I'm going to make, again, this one up. An organization wants to work with you to develop an algorithm for the geriatric population. I would guess that for your institution, that would not be strategic. So look at what disease states, what patients, what communities, what do you want to serve? What's strategic? Then ask impact. Well, will this impact 4 patients or 4,000 patients? I actually did have somebody come to me and say, I have an amazing algorithm that will reduce readmissions of those with advanced cirrhosis. I said, great, how many of those do we have? 4. Right, okay, well, put that one on the defer pile. Then you ask safety, quality, right? Is there an issue where you're seeing sentinel events and you could start to help with safety and quality improvement through the use of AI? I would guess that sometimes you also have regulatory compliance. And if there is an issue where, for us to deal with what is legislative or regulatory requirements, maybe that's a priority. And then finally, I left this one to the last, but I do want to mention it. We all live in a time of economic stress and margins are thin. And you might want to ask the question, if there is an area you could pursue that will provide you additional resources so that you can continue your mission, then that may very well be something that is also a priority item.
Thanks so much for that wisdom, John. Very, very helpful. Okay, other questions? I see Ivan has his hand up. Ivan is our Director of Research Informatics and Technology at the Research Institute, and AI falls under his portfolio. So Ivan, over to you.
Hey, John, fantastic talk. It was particularly inspiring that you have a Canadian organization that's participating in this initiative, because one of the things we always deal with is how do we connect with international partners, privacy legislation being what it is. My question to you is around the cost of engaging in something like this. As we all know, cloud computing isn't free. A lot of the stuff you're talking about is very compute intensive. How does one organization think about starting up this sort of initiative? Are there supports available? Certainly, you mentioned some de-identification tools and things like that. I would be very interested in discussing. But I guess I certainly understand why we would want to participate in something like this. It's more for me like, how do we get there from a feasibility and cost perspective?
Really great questions. And so every society that we work with has different qualities of data, right? Contents they've gathered over the years, different EHRs, et cetera. So for example, and I'm just going to give you a real one, Aga Khan came to us and said, we would like to de-identify all the data of Kenya. And so our data scientists studied it. The cost of curating, normalizing, and de-identifying the data of Kenya is about $500,000. And it's just the nature of their data. And so I went to a philanthropist and said, would you fund $500,000? In fact, could you give us $1 million gift to help with the curation and cloud costs for ongoing storage and compute? And the philanthropist said, absolutely. So it was a pretty straightforward thing to raise philanthropy for some of this. But, I would guess, it's just a guess, it's going to cost you $500,000 to $1 million to do all the data DID of all your modalities and moving it into the cloud in an OMOP format and that kind of thing. And you'll have to make decisions on hybrid compute, right? Cloud costs, as you say, especially for GPUs, can be substantial. And so what did Mayo do? Although a lot of our work is done in the cloud, a lot of our generative AI work is not done in the cloud. It's done with hardware that we have been able to borrow or was donated to us that is substantially cheaper to operate than cloud GPU costs. So it's real. And you will have to make that balanced choice based on resources you have available.
Thanks, John. Ivan, thanks for that question. We'll next go to Khaled, and Khaled is an AI scientist and actually holds a Tier 1 Canada Research Chair in Medical AI, and so look forward to his question. Khaled.
Hello, good morning, John. Thank you very much for that. I just wanted to ask you a little bit about the FDA approvals that you mentioned. And when do these come in? I mean, do you need those in order to deploy algorithms only internally within Mayo, or when you start distributing them to other sites, or when you commercialize them, or do you have to get the approvals when you use them only for research purposes? What does the regulatory landscape look like for these types of algorithms?
So I'm going to answer that question at a slightly high level because, of course, I'll be happy to put you in touch with David Vidal, who is the attorney at Mayo, who did the very first FDA approval in the United States and is the national expert on FDA approval lifecycle. But it goes something generally like this. Suppose we've developed an algorithm for population health. Screening tool decides when patients should be evaluated, makes general recommendations about their wellness. FDA does not regulate population health. So we deploy those algorithms after doing quality assurance ourselves, but there's no FDA process. Suppose we want to try an algorithm inside Mayo. Well, we go to IRB and human subjects, but we don't go to FDA. And so it's under the auspices of we're doing this as a research project inside the organization. And that's the way we initially deployed all these cardiology algorithms and put them into clinical practice under IRB and human subject review. Ultimately, then we decided to bring them to the world. Then we went to FDA and said, here's the data. Here's the quality management system. How is it developed? How is it tuned? How is it monitored? And FDA ultimately gave us the full software as a medical device approval, which then enabled us to sell that in a commercial marketplace. And the FDA considers these things medical devices. So sure, your internal controls can be done without regulatory oversight. But the second you really want to bring it outside, if it is truly a diagnostic and therapeutic intervention, not just pop health, then you're going to need regulatory oversight.
Okay, great. Thank you.
Thanks, John. Michael.
Thank you very much for a very interesting presentation. I'm just wondering, do any of the algorithms in development communicate directly with patients? For example, sharing information about health-related behaviors rather than bearing directly on medical treatment-related decision-making?
So again, you ask a really interesting question. And so our cardiology algorithms, you may be familiar with the Echo, EKO stethoscope, or there's something called a live core, which is a cardiology monitor. Actually, Mayo algorithms are inside these things. And so that means a consumer can go buy one of these things on Amazon and is saying, oh, well, I'm looking at risk of AFib or prediction of this or that cardiology disease or dysrhythmia and that kind of thing. So there are examples of consumer-facing AI deployed. But it is interesting to your point. Mayo is more of a B to B to C, which is we're going to take the caregiver, doctor, nurse practitioner, inform the caregiver. The caregiver is going to work with the patient. Very rarely do we go directly to the patient. In the world of generative AI, I'm going to make a probably bold statement right now. We have zero plans to give generative AI products directly to patients for their use without scrutiny, because the things are so filled with fiction and hallucinations. We're fine with giving it to a clinician, and the clinician decides what to use and not, but not a patient directly at this time.
Thanks, John. Michael, did you have a follow-up? Okay. Next, we'll go to Dana Radhakrishnan, and Dana is our academic and medical lead for informatics and AI. Over to you, Dana.
Very nice to meet you, John. Very nice talk. I have two questions. I'll try to be brief in asking them. The first is with respect to implementation. You touched on it when a larger center has developed some type of a medical AI solution, and then it's being deployed in a smaller community center, and you kind of sell it in a way that is value add for them. And I appreciate that. But how about at the development stage? I'm just curious as to your recommended approach. Do you have a clinical group who's vested, who is developing the questions or the gaps that are needed to be solved using AI? Or do you have a different group of more, let's call them computer scientists or engineers, who have a sense of what might be valuable and then sell this to the larger clinical group, for example, at Mayo? That's my first question, if that makes sense. The second is with respect to the patients again. Have you encountered hesitancy or fear or mistrust on their part if they come to know that their data was used for developing these AI products and now they're being used for their decision making in their medical care as well?
Both amazing questions. So the answer to the first is yes, which is the way that Mayo is organized. Remember, we have what are called sites and shields. Our shields are practice, education, and research. So our data scientists, our informaticians, and our AI experts on the math side are in the research shield. The clinician experts defining the problems, looking at clinical relevance, looking at things like usability and impact are in the practice shield. So in fact, we have both groups, the math-driven ones and the clinical-driven ones. So every algorithm goes through a mathematical validation and a clinical validation. And the teams work very closely together in an integrated life cycle. So you need both. I totally agree. And your second question about patients. So when we decided that we were going to do this de-identified data behind glass, we vetted this very widely. And of course, that went through regulators and it went through all of the usual suspects in an academic medical center. But we also went to the New York Times, the Washington Post, and the Boston Globe and said, this is our plan. And we were really public about how we were going to do it, why we were going to do it, the fact that a patient can opt out at any time. And of our 10 million patients, 3,000 have opted out. So there will always, sure, it's up to them. And it's your personal decision. But by and large, their belief in, oh, you mean my experience can help the next person like me? Oh, that sounds great.
Thanks, Dana, for that question. And thanks, John. And we're in the process of launching a opt-out research model called Research Connections here at CHEO. And so it'll be, it's encouraging to hear about that percentage of patients that the majority of whom really support and buy into an opt-out model. And maybe for our last question, we'll go to Jeff Gilchrist, who is a senior AI scientist here at CHEO. Over to you, Jeff.
First of all, thank you for that very interesting presentation. So I have a question that's a bit maybe more in the weeds. You said that you sort of standardize on Smart on Fire sidecars for providing the results or interface with your AI models. I was wondering if you've also standardized on some kind of frameworks or tools or languages for creating these different AI models? Do the groups just build whatever they want and whatever language they want? Have things been standardized to a certain type of platform, like using Python code or specific toolkits? Or I guess what's the sort of process that happens behind the scenes with your 240 algorithms that are in place now?
Well, what a great question. So let's start at the data layer. So every participant in our global network uses something we call OMOP Plus, which is International Standard Schema through the Standards Development Organizations for OMOP, but then we extended it for genomics and digital pathology and some of the other elements that weren't quite yet in the standard, but it's all done through standards organizations. All the APIs are FIRE-R4 normative edition, again, working with HL7 to extend those schemas as needed. So you've got the whole data layer standardized. Then we built on top of that 3 kinds of tooling. One is what we call a no-code tool, and it happens to be called Mayo Clinic Platform Discover, but we make it available to everybody. We have 82,000 employees. Any employee can use the no-code tool, and it's things like, I will go in and I will define cohorts, I will define endpoints, I will create a model, and it's all done in one way with no code. The second is what I'll call moderate amount of code. You know, if maybe you're a little more sophisticated and you want to go in more at the schema level and deal with data filtration and curation a little bit more. And then there is a third environment, which is the high code environment, where we bring in PyTorch and all the Google, and we happen to have a relationship with Google. I'm not endorsing any cloud provider here, where they have brought a suite of tools in something we call an AI factory. And then anyone who wants to do the high code approach can lift any tool from the AI factory, including now generative AI capabilities. And we've got Llama 2 and other things in there. So how about this? Yes, we standardize as much as you can, but we also give people capacity to play in a high code environment with a variety of validated tools.
Thank you very much.
Thanks very much, John. We are at time. So on behalf of the Department of Pediatrics at CHEO and our AI team, just want to thank you for joining us this morning and for sharing your wisdom, really thought-provoking and inspiring. The Grand Rounds evaluation link is in the chat, so please complete that. And John, we look forward to future discussions as we continue to build our AI program. Thanks very much and have a great day, everyone.
Thank you so much. And my Nexus card is up to date. See you soon.
See you soon.